Hello, my friends. Dr. Ken Berry here with you today. I have a wonderful guest, and we're going to talk about practical things that you can do to help a loved one with Alzheimer's or with Parkinson's or even with Huntington's and perhaps even with glioblastoma. We're going to be talking about all things brain related, dementia related, neurology related. I have with me today special guest, Dr. Matthew Phillips. Welcome, doctor. So glad to have you on.
Thanks, Ken. Great to be here.
Excellent, excellent. So, I'm getting some feedback here. I'm not sure why that is. Okay. All right. Anyway, hopefully nobody in the audience can hear it. If they can, tell me. So before we get started, this is good. We got lots of ground to cover today. So we may or may not be able to take questions from the audience. If we can, we will. Tell us briefly, I've included a brief CV down in the show notes, but give us a brief kind of background on you and how you came to think about dementia and other neurological diseases as metabolic disorders.
Sure. So in brief, I'm Canadian and did two degrees in Canada, science degrees, and then came to Australia, where I spent 12 years training in medical school and in medicine as a neurologist, first in Adelaide, then in Melbourne. And at the end of that, I wanted to specialize in therapies. There wasn't really an option to specialize in a therapy in neurology. It was all about specializing in perceived disease processes such as stroke or epilepsy or Parkinson's. And so I sort of took a self-imposed 3-year fellowship where I traveled around the world a bit and volunteered in other countries and had a lot of time to think about these things. And I thought about a lot of possibilities as to what could help people with the most difficult neurological disorders, because I realized I was really frustrated at my inability with the current medical thinking to help people with Parkinson's, with Huntington's, with glioblastoma, and other similar things. And so I ended up thinking that metabolic strategies, fasting, keto diets, and the like, might be very beneficial for these people. Came to New Zealand. Initial plan was 1 or 2 years, and here I am almost 8 years later, piling along on the research into these therapies. That's it in a nutshell.
Excellent. And I'll tell you, as a family physician, primary care doctor, there are some referrals that I make to specialists that are very helpful. For instance, if I have somebody I see in the emergency department with a compound fracture of the tibia, I send them to the orthopedic surgeon, and I see them follow up a couple of weeks later. It's fixed. They're healing. They're getting better, right? But one of the most frustrating, I learned very early in my medical career, when I sent a patient for a neurology referral, I typically got no useful information back from the neurologist. I typically got no improvement in the patient. They may have gotten started on 1 or 2 or 3 different medications, but invariably, as I followed that patient every 3, 6, or 12 months, it was a gradual progression to worsening of the disease. There was never a moment when I got a referral back from neurology and said, "Oh man, hey, that was a home run. That really helped my patient a lot." And so I don't know if you feel that on your end as the specialist, but man, as a primary care doctor, neurology never really helped me at all.
Yeah, you and I share the same frustration.
Gotcha. So we're going to be talking today about Alzheimer's dementia. We're going to be talking about Parkinson's disease. We're going to be talking about Huntington's disease. Everybody watching this, you know someone and probably love someone who's either suffering from the early, middle, or late stages of one of these conditions. And so if you know someone or love someone that has one of these conditions that you would like to help, this is the video that I would recommend that you watch. Hit the thumbs up. And if you haven't already done so, subscribe to this channel. But I promise you, you want to share this video with someone if they're taking care of a loved one who has Alzheimer's or Parkinson's or Huntington's. Let's start with, do you want to start with your slides first, or do you want to start with a particular condition?
No, slides are good. We can do the conditions after the slides.
All right, let me get these slides loaded up, and we'll start with your slides, and you can just kind of talk us through this.
Sure. So there's only 5 slides, so we can take a bit of time for each. But first, I'd like just to say that A little bit on how the brain works. Brain does not really work based on logic or reasoning. It works on beliefs, perceptions. So, and this is one reason why there's so much debate in the medical community and outside the medical community as to are keto diets good for people or are keto diets bad for people? Because the brain actually works on beliefs mostly, and it's very difficult to change a belief within a conversation. So if you think of like David Hume, that Scottish philosopher, said, a wise man proportions his beliefs to the evidence, which means you should actually, look at facts and reality and build your beliefs about reality based on that. But I think, unfortunately, most people at the moment are doing the reverse. They're proportioning their evidence based on their beliefs. And so you can look at the study that, for example, you went over with Nick recently, Ken, and the authors argued that keto diets caused a problem in that man with atherosclerosis, but you could, based on your beliefs, equally argue that the statins caused the problem in that man as well. And it just depends on, So, and a lot of the problem with this belief thing is that so much evidence now is observational. It shows correlations only and associations. And when you have that, and a person can, based on their beliefs, say this X caused Y, or they could say Y caused X. Because with all this data from observational studies being correlational, you can't figure out causation in any way. But it's a human brain's nature to draw causation. So I just want to prelude that and saying basically this whole talk is a lot about beliefs. They're crucial. Now, the split in the medical system, I think, started 200 years ago, probably even earlier to an extent, but a defined one 200 years ago. These two gentlemen here, Louis Pasteur and Antoine Béchamp, they were both living in France. Pasteur was a French scientist, Béchamp a French medical doctor and scientist. Pasteur championed germ theory, which is a theory that's still strongly applied today in many other aspects of medicine, not just infectious, but also many, the non-infectious disorders. We're trying to use germ theory. And this is basically that there's some kind of target, a pathogen or some other target that's causing a disease, and you have to suppress it or eliminate it.
Yep.
Béchamp had this sort of opposite theory called host or terrain theory. And he saw that most pathogens were scavengers and that the terrain, the health of the body, broadly speaking, was the problem, was the thing that we had to improve. And if we did that, most pathogens, not all, but most wouldn't be a real issue. And there was this debate between these two guys. And basically, one believed germ theory and one believed terrain theory. The truth is probably that both had good things to say. And, we shouldn't have picked one, but we ended up picking germ theory for various reasons. Béchamp wasn't a great speaker, and he did have some things that were perhaps not so good to say with his terrain theory, such as this concept of Alzheimer's, which I won't go into. So that's the first slide, and basically outlining this sort of germ theory versus terrain theory thing. And basically, terrain theory has been lost. Germ theory now dominates medicine in all ways. And there's this sort of recent rise in terrain theory, particularly amongst non-medical outlets, which is kind of good to see, but it has yet to make any serious inroads into medicine. And we're going to be talking about a combined approach of germ theory and terrain theory today, but emphasizing terrain theory because it's been so underutilized in the past.
Absolutely. And let me just add, the entire pharmaceutical industry today, all the billions of dollars worth of it are based entirely on the germ theory model. Either there's a pathogen that you need to wipe out or treat or eradicate, or there's a particular molecule in the body like LP-little-a or ApoB or TMAO that you need to do something about. And invariably, the do something about part is, we've got a pill, an injection, an infusion, or surgery. That is invariably the answer when you use the germ theory. And I agree with you about the terrain theory. There were some obvious, glaring, unnecessary errors made in the terrain theory initially, and then subsequently, a lot of people who believe in a lot of woo-woo have latched on to the terrain theory, unfortunately, because I think there's a lot of good theories and a lot of good principles in the terrain theory. I recently tweeted that in order for a doctor to be truly a good doctor, they need to be able to simultaneously hold the germ theory and the terrain theory models in their head at the same time. And I got so much kickback for that tweet. I think it was quite telling how many people got triggered by that, not understanding all the implications behind it. So yeah, I think when we diverged and went 100% into germ theory, because that's where all the profits are. There's not a lot of profit in making people healthier and more resilient and maybe even anti-fragile, but there's billions of profits in treating a microbe or treating a molecule. And so I think you're exactly right about that.
Awesome. Okay, second slide. So because germ theory has dominated for 200 years, we've really done a great job with infectious disease processes. They're no longer in the top 10 causes of death in any Western country, to my knowledge, certainly not here in New Zealand. So if you look at this graph on the right, this is New Zealand data. It would be similar in the US and Canada and so on. The top 10 causes of death are pretty much dominated by lifestyle-related disorders. Number one would be at the top, atherosclerosis, which is the main cause of heart attacks and probably most strokes. I see strokes on a daily basis. It's the number one condition we see in the wards in neurology. Number one in some countries would be cancer, including cancers of the brain, of course, but many other cancers of the body. Neurodegenerative disorders like Alzheimer's, Parkinson's, motor neuron disease, Huntington's. There's a few bars in the middle there that encompass those. And you could also throw in a lot of the sort of mental health conditions. And number four, metabolic syndrome is not really specifically mentioned on that graph, but it kind of dominates basically all those blue bars. Metabolic syndrome, which is that combination of impaired fasting glucose, central obesity, high blood pressure, and then triglyceride and HDL, cholesterol abnormalities, is sort of like a platform for all these things to build on. So you can basically break that graph on the right down into four main processes: atherosclerosis, cancer, neurodegenerative disorders, metabolic syndrome. And those are the four big sort of lifestyle disorders that I believe we need to address that are killing the most people today. I'm focusing personally with my research on cancer and neurodegenerative disorders at the moment for various reasons. But I, of course, see a lot of atherosclerosis, metabolic syndrome in my research work, but also clinically. Now, we've tried to apply germ theory for 200 years, and I think the application, we've taken germ theory very, very far, and that's why we have no infectious diseases anymore, or very little. They're sort of number 11 on that graph. Whereas that would have been very different in Pasteur and Béchamp's time, that infectious diseases would have dominated. And partly because we've applied germ theory so strongly, it doesn't work against these lifestyle disorders. So they've been allowed to flourish because we have no terrain theory to address them. And terrain theory is much more suitable for the lifestyle disorders. So, the massive application of germ theory it really isn't working. And we have to acknowledge that first. That heart disease is going up, cancer is going up, Alzheimer's is going up, Parkinson's is going up, above and beyond population growth. And if you look at these things, hundreds of papers you can read, they're all linked by impaired mitochondrial biology. And mitochondria are these little hundreds of thousands of little organelles, they're called, that run around cells, and they move around the cells. They produce tons of energy for the cells, but they do a lot of signaling functions for the cells. They actually coordinate cell metabolism to a strong degree. They're involved in producing steroids and all kinds of things. So I used to use the term mitochondrial dysfunction, but now I'm leaning towards the term impaired mitochondrial biology because they're their own thing. And unfortunately, Béchamp didn't really know about those. They weren't really discovered 200 years ago. It was shortly after that they became discovered. And so perhaps if he'd known about them, he could have applied terrain theory to the mitochondria, but rather than using other things that were less ideal. And so what we'll talk about going forward from this slide is not terrain theory per se, because there were so many problems with it, but a health-oriented theory as opposed to germ theory, which is a disease-oriented theory. So germ theory is about eliminating, suppressing targets, which isn't working for these lifestyle disorders. terrain theory or something like it, a health-oriented theory, would be more about restoring mitochondria biology, which I think is the main problem with these disorders, because if you look at them across the board, the mitochondria are messed up on many levels.
Absolutely. And one of my first experiences with the failure of the germ theory model was when Aricept first came out. And so for decades now, billions of dollars have been spent by pharmaceutical companies trying to combat the neurofibrillary tangles in the Alzheimer's brain, thinking that's the root cause, that's the underlying problem. Again, the germ theory, there's a thing. Let's come up with a drug to work on the thing. And I was so excited when finally it was covered by Medicare. And I'm like, all right, we're going to start helping. And I had maybe 20 Alzheimer's patients in my family medicine practice, put them all on it, see them in 3 months, nothing. See them in 6, see them in 12, see them next year, literally just chronic progression, no improvement whatsoever. And it was at that point I was like, maybe there's more to this than just, you got a condition, here's a pill. And I want to get personal with everybody watching. I want you to tell me in the comments, do you have a loved one with Alzheimer's or Parkinson's or Huntington's? Tell me who the relative is, dad, mom, grandmother, uncle, aunt. Put them in the comments. You can put their name if you want to, but no identifying information, because I want you to hear me. This is real. This is real stuff we're doing right here. And this can absolutely improve the health of your loved one with one of these neurological conditions.
Cool. Slide number 3. So this is how we currently think about disease and health in the medical system. So I call this the disease-centric paradigm. It's based on germ theory. And this is really simplifying things, but we're trying to convey the broad brushstrokes here, obviously. So essentially we have all these lifestyles disorders that are, fulfilling most of the top 10 causes of death, if not all of them. And they're essentially seen today as many different disease processes, and it's not quite clear what the cause is. So if we talk about the 4 main ones, it's thought that early on in all these things, you get some kind of target, as Ken said, that becomes abnormal. So for the metabolic syndrome, in which type 2 diabetes is perhaps one of the main components, it's this rise in glucose, this inability to metabolize glucose well, and you get this sort of impaired fasting glucose. So glucose is just a little too high in the blood. And so that becomes a target. Physicians want to focus on lowering the glucose. And we know that there's a lot more to type 2 diabetes than the glucose. If you look deeper, you really have to address the insulin resistance underneath the glucose. And I guess my view is even deeper than the insulin resistance is, why is the insulin resistance there? And I speculate that it may be a mechanism, possibly protective by the mitochondria, to mitigate the basically overwhelming negative impact of glucose spikes on mitochondria, because they don't repair well, they don't like it. So if you have this repeated, glucose influx into the body, the mitochondria have to deal with a lot of that, and they erect this insulin resistance to mitigate that process, so they don't get this thing called electron overflow, which leads to mitochondrial overload and damage. Okay, so that's the way I see it. I see glucose intolerance, type 2 diabetes, metabolic syndrome as a mitochondrial problem ultimately. Now, if we go to the second column there, LDL cholesterol often, not always, rises in people with atherosclerosis, a hardening of the arteries disease that causes heart attacks and strokes. And a lot of people with heart attacks and strokes don't have a high LDL cholesterol, so it doesn't make sense as a cause, but we still target it because it often is up. So, and as Ken said, it's an easy thing to target. Genetic mutations are often seen as the initial disease in cancer, despite the fact that 20 to 30% of all cancers don't actually have any genetic mutations, so they don't fulfill sufficient causal criteria either. But we still target those. We're trying to target those in research with gene targeting methods. And finally, the amyloid and tau. Tau is the main protein in the neurofibrillary tangles that Ken mentioned. And these are the things that are thought to cause neurodegenerative disorders like Alzheimer's. And they often occur early, but they don't fulfill causal criteria very well either, because You can get people with very bad Alzheimer's that don't have much amyloid or tau at all. And then you can have people with no Alzheimer's, like they're cognitively normal, and they have quite an abundant amount of amyloid tau in their brain. So basically, but this is, it's a simple way to look at it, and it's easy to target these things and try to suppress or eliminate them. So all these things are seen as disease processes. And I should add, the glucose intolerance on the left there in metabolic syndrome, central obesity is another one. And again, I don't see obesity as a disease. I see it as something else. It's more of a metabolic response to a problem, actually. So we'll talk about that more on the next slide. So what ends up happening is people, we sort of see that these diseases, these perceived diseases, start out like this, and then after years and decades, they become late stage processes like type 2 diabetes, like atherosclerosis, like cancer, like neurodegeneration. And so we keep thinking, if only we could get there, target these things more, if only we could get to these people earlier and target these things more. It's all germ theory, right? So again, it's this pervasive belief in germ theory that we're trained in from day one of medical school, that all these things are diseases, that we need to find the right thing that's causing them, target it, suppress it, and eliminate it like an infection. Okay, so this is how we see things in medicine, and this is so important to understand. If one understands this, and you can see how all the debates on social media and in the medical mainstream medical journals appear, and why mainstream medicine tends to favor this germ theory approach and defend it very rigorously, because it's based on a belief. Whereas there are a lot of people that are perhaps more supportive of the terrain theory approach that are also trying to defend that too much. And as Ken said, I love it when you spoke about your tweet, Ken, the middle road is the hardest one to walk. And yes. I agree with you on that. I think germ theory and terrain theory both have a role. And, we've done amazingly well against infections with germ theory, but now it's time to redress the balance. We need to get a little bit of terrain theory in there, or something like it. Get away from Bischoff's wording, because his concept was very not the greatest of it. But something like terrain theory. We need to get a health-oriented approach in medicine going, and address these things better, which the next slide will talk about.
All right.
So slide number 4. If you're still with me, you're doing very well, because there's only one more after this. This is the way I see the future, sort of a health-centric paradigm. And again, I'm really simplifying this. It does not take away the use of medications in these disorders, so Alzheimer's, Parkinson's, cancer, at all. You can still apply germ theory, but it does redress the balance, and perhaps suggest that the germ theory approach is far less useful in these disorders than the sort of health-oriented approach. So I see, and please remember, this is my interpretation of the evidence. So, always be skeptical of everyone. But I see these lifestyle disorders as essentially all different manifestations of a single disease process of impaired mitochondrial biology, or in simplistic terms, mitochondrial dysfunction. The mitochondria get damaged very early on in all these things. So type 2 diabetes and the metabolic syndrome, atherosclerosis, cancer, neurodegenerative disorders like Alzheimer's, they get damaged very early on. And when they get damaged, I see a series of, initially the body tries to erects a series of metabolic responses to the damage. And often these things are actually protective. So glucose intolerance, if you can think of mitochondria getting damaged from simply looking at diet, I guess, too many processed carbohydrates too many times throughout the day, it's a constant overload on mitochondria to deal with all that glucose, which leads to respiratory chain overflow in the mitochondria. So they basically get overwhelmed with energy. And so you get this insulin resistance. So the cells become a little resistant and say, nope, we're only going to allow so much glucose in. And then the glucose in the blood goes up. You get a, glucose intolerance. And to me, that makes a lot more sense as sort of the cause of all things. And as that process continues over years, the mitochondria produce insulin resistance, and then the body wants to get the glucose out of the blood. So the pancreas pumps up the insulin to overcome the resistance. You get this C-sign battle for years where your insulin resistance is going up, your mitochondria are still getting more damage. Then you get type 2 diabetes. Your body's trying to take all that extra glucose, shunt it into fat wherever it can, because it doesn't store glucose very well. The body doesn't store glucose well, it stores fat well. So you get obesity because the fat accumulates all throughout the body and all these other things. So that is like an initial response to me. The cholesterol, does go up in many cases early on in atherosclerosis, but again, it's observational studies there that that we know that. So is that the cause of atherosclerosis? Is that an epiphenomena, like it's just correlated with it, or is it even a protective response in the setting of atherosclerosis? Right? We don't know, but all those options are on the table, and I suspect it's an epiphenomenon, possibly protective, but it's at least probably an epiphenomenon in large part. Genetic mutations do often occur in cancer. As I said, they don't always occur in cancer. I see those as a response to mitochondria damage, because the mitochondria produce the energy for the cell, including all the repair processes. And when those go down, mutations can occur because the cell is constantly repairing mutations all the time. And if you have suboptimal energy, as you do in cancer, then you're going to have mutations that become unrepaired. And this would explain why they're all random, and mostly random. And then you have amyloid and tau accumulation as a response in Alzheimer's and Parkinson's and so on as well. So, why does this go? Is this partly causal to the process? Maybe. Is it an epiphenomenon to the process? Is it, some people think amyloid and tau are protective in Alzheimer's because the neurons that have them actually seem to do better in a lot of cases. So these are all, but the point is, these are all responses to the real disease, which is a mitochondria problem. And so we're trying to treat, with germ theory, we're trying to treat responses, right? And it doesn't make sense. You need to get above to the top of this graph and fix the mitochondria. And of course, if you let all these responses go, more metabolic responses come in, and these ones are maladaptive and decompensatory and not protective. And then you get your diabetes, atherosclerosis, cancer, and so on. So this paradigm emphasizes restoration and renewal at the top level, whereas the one I showed you before emphasizes suppression and elimination of the middle level. And for these lifestyle disorders, you want to treat the top level.
Absolutely. And you think the mitochondrial dysfunction or malfunction is kind of the very root cause of all these metabolic diseases?
Yeah, I do. I recognize that's a very strong stance. Obviously, I've thought very hard about this before coming out and saying it. In fact, I was very nervous to come out and say that. But I think I'm on safe ground there. The more I learn about mitochondria and just how complex they are and what they can do, these things don't just move around the cells; they move outside the cells. They go in the bloodstream. They don't need cells. And I actually am seeing more and more. We always taught, Ken, that cells were the fundamental unit of life, the elementary unit of life in organisms, and I actually see it as mitochondria now. And I guess one must always, maybe 10 years from now, be looking at myself and going, "Why did I say that?" But I don't think so. I think it seems like the right thing, and to me, and also it's exciting because mitochondria are highly dynamic. They can actually rejuvenate themselves if you allow them to, if you give them the right methods. And this is where the fasting keto diet things come in, because to me they're essentially aimed at improving mitochondrial health. And a lot of times people use them for other reasons, weight loss, and so improving diabetes, good things. But at the end of the day, you should be on these metabolic strategies, in my opinion, to improve your mitochondrial health. And if you improve your mitochondrial health, you improve your health, because to me, that is the essence of health.
Absolutely. And Dr. Phillips kind of let the cat out of the bag, because please stick with us. Once we get through the science and kind of the foundational philosophy of what we're talking about, we're going to start talking about practical tips, things that you can start today or tomorrow with either you, if you're worried about developing one of these neurological conditions, or with a loved one who is already in the early stages. We're going to have practical, applicable tips that you can start using tomorrow morning to slow down progression and perhaps even reverse progression with several of these diseases. Dr. Phillips has several research studies, one a randomized controlled trial in humans, another a randomized crossover trial in humans with these specific conditions. And so if you want okay, step 1, step 2, step 3, we're going to be talking about that just in a few minutes. All right, doctor, next slide.
Okay, last of the slides. So well done for making it this far. So now we're going to compare the hunter-gatherer versus modern dietary lifestyle. And I hope to relay why I think that sort of a more hunter-gatherer dietary lifestyle is really optimal for cancer, neurodegenerative disorders, and so on, all the lifestyle disorders, essentially. I'd like you to look at the one on the right, the red figure first. So this outlines the modern dietary lifestyle. So I'm dumbing this down to two main things. If you look at the modern dietary lifestyle, the things that have changed the most in the last 100 years, yes, there's been incorporation of seed oils and all these other things, yes, undeniably. But to me, the big problems are we eat too many times throughout the day, multiple daily meals and snacks. A lot of people are eating not just 3 meals a day, which in my opinion is too much. They're eating 4, 5, 6, or even more. And then the second thing is a high intake of processed carbs. Processed carbohydrates, I'm sure Ken has gone over this many times, sugar, refined things, grains, cereals, so on. So those two things, too many meals and snacks throughout the day and processed carbs, these are really very abnormal from a hunter-gatherer point of view. If you go back 10,000 years, before human agriculture, you have sort of a couple million years of hunter-gatherer evolution. And that's what our body and brain have adapted to. 10,000 years sounds like a long time, but it's not very long in evolutionary time. And we are really adapted to hunter-gatherer metabolism and a hunter-gatherer dietary lifestyle. And I'm just going to say, people say, well, hunter-gatherer, a lot of people say hunter-gatherers died at a young age. Okay, so first of all, we don't know much about hunter-gatherers, but you can look at modern hunter-gatherers to get decent data about this. But a lot of hunter-gatherers did have a lot of infections, trauma, and childbirth-related complications and infant mortality, which all skews the picture a lot. And I think there are good reasons to think that hunter-gatherers, if we could have addressed those things, they would probably live a very long time. And there's evidence that some of them lived very long anyway, 60s, 70s. So, and maybe 80s. So
yeah, and let me jump in right there,
Go.
Dr. Phillips, and add in my over the last few years, I've been reading extensively anthropological literature, and no anthropologist talks about average lifespan because it includes all causes of death at any part anywhere on the life cycle. And so if you're trying to compare, okay, what's our average life expectancy as modern humans versus 20,000, 50,000, 100,000 years ago, you have to understand that they had no access to, if they got an infection, that was a death sentence. During childbirth, very dangerous time. The first a month after childbirth for the baby, very dangerous time. And then the childhood adolescent period, and then also the teenage years when the hormones are raging, trauma. And then in the 20s, trauma, whether violence or whether accidents. When every anthropologist that I've read says, when you take out the childbirth deaths, when you take out the infectious disease deaths, and when you take out the trauma deaths, that human beings 10,000, 20, 50,000 years ago most likely live just as long as we do today, if not a little bit longer. And so I see this argument on Twitter all the time. Well, the average person 20,000 years ago died when they were 30. So you can't say that's the proper human diet. It's like, and it would take days for me to explain to everybody on Twitter, no, you're wrong. But so many people try to make that argument, well-intentioned, but just completely and totally ignorant of the anthropological facts.
Thank you, Ken. That's really good. Okay, so just returning the figure. So I've split this modern dietary lifestyle into two main problems. In the gray there, we've basically got people eating too many times a day, and when they do eat too many processed carbs, it leads to excess anabolism, which just means metabolic growth, essentially. So you get these frequent glucose spikes. You get all these growth promoting signaling molecules like insulin, IGF-1, mammalian target of rapamycin, the mTOR, which is quite infamous. And you get this basically electron overflow and overproduction of advanced glycation end products or AGEs and NADH, and the mitochondria get overloaded. Now, to the right of that in the white box, you also have insufficient fasting periods. And the fasting periods are really important. You need to balance your feeding periods with good fasting periods, because the first one is all about growth. The second one is all about sort of growth and anabolism. The second one's all about catabolism, which is breaking stuff down within the body. And we need to build stuff up and break stuff down, because the breaking down is important. It allows us to recycle things and renew many things that are junky or old in our body, like proteins. So the modern dietary lifestyle has too much anabolism on the left and not enough catabolism because we don't have proper fasting anymore on the right. And this is a real problem for mitochondria at the bottom. The mitochondria get exposed to tons of oxidative stress from every time we have a big glucose meal. And they also undergo insufficient renewal processes because they need a long time. The fasting process, the fasting periods is where the mitochondria can renew. They undergo something called mitogenesis, which is the birth of new mitochondria, and mitophagy, which is the breaking down of the old chunky ones. So recycling stuff. And both these processes are imbalanced. The gray one is far too much in the modern dietary lifestyle, and the white box is insufficient. Now, if you go to the left, the green figure, this is the hunter-gatherer dietary lifestyle. So again, I'm focusing on dietary lifestyle here. So the hunter-gatherers obviously had frequent periods of food scarcity, and they ate wild foods. These wild foods had they had no processed carbohydrates. They didn't have almost none. So what they had was ketogenic, low-carb diets pretty much across the board. In some cases in the grasslands, from what I've read, low to moderate carb maybe, but even in those cases, there was a ton of fiber to mitigate the impact on the mitochondria, right? Fiber is like it's a carbohydrate, but it's like an antidote to it. It really mitigates the impact on you metabolically. So their gray box, their anabolic periods, their periods of growth were characterized by more, rather than spikes, infrequent plateaus in blood glucose and insulin and all these growth factors. And so this led to sort of levels of advanced glycation end products and NADH and electrons that the mitochondria could handle. They could handle it without too much damage. And then the white box was much more pronounced in hunter-gatherers. They underwent frequent periods of food restriction, fasting. They would have been enforced at times when they'd have to go for a few days with minimal food intake and so on. But the mitochondria take advantage of this process, and we know this happens, that this is when they undergo mitogenesis and mitophagy, and they renew themselves. This is a really important thing, to have this balance of feeding and fasting. And so the bottom of that one, the impact on the mitochondria, was that they ended up undergoing relatively modest oxidative stress that they could recover from, and they could recover from it because we gave them enough time to undergo mitophagy and mitogenesis during these longer fasting periods. And that, again, it's all very looking at things very simply, although I hope it doesn't seem too complex, but we've just lost this hunter-gatherer balance. And now, as Ken says, now that we can treat infections so well, we can treat trauma so well, as you said, Ken, you can get a broken bone and fix it within a few weeks. And we have much lower childbirth mortality rates and infants mortality rates. So, germ theory and modern medicine has done wonderful along those lines. But now, it's these lifestyle disorders that our hunter-gatherer ancestors never really had to deal with to any significant extent because of this balanced dietary lifestyle. Now we have this opportunity. It's such a great opportunity to introduce a hunter-gatherer sort of dietary lifestyle and combine it with our modern medical methods. And the sky's the limit in terms of human health optimization now. And this is the main message I really try to focus on, is there's so much positivity here. If we could harness this dietary lifestyle in the modern era, I think we could really take humanity to levels above and beyond in terms of health.
No, I totally agree. I think that's so well said. Take all the good things that we've gleaned from our decades of following the germ theory with regards to every single disease. We learned a lot of stuff, especially for trauma, infection, and childbirth fatalities. But now let's start to consider the terrain. And I agree with you totally. I really wish we could come up with a new term for that, because that term is so loaded. But I know what you mean by that. The health, the underlying health, metabolic health of the individual. That's super important. And if you could marry those two things, everything we've learned that's useful in modern medicine with everything that our bodies have learned over the trial and error experiment of life on this planet for as long as we've been here, when you marry those two things, I think you're right. I think it's blast off at that point for human health. And so let's turn now to, if you're finished with this slide, let's turn now to the specific conditions that you've done research on, what specific things you found, and what specific recommendations, if any, we can give to people watching this right now, or that they can, when they hear what you have to say, they can share this with someone and say, hey, you need to watch this right now, because this could literally change grandpa's trajectory, maybe even get grandpa out of the nursing home, who knows. So let's go from there.
Yeah, I know of cases where that has happened. Absolutely. So I would just say one thing. My view of terrain at the moment, I would define the terrain as optimized mitochondrial biology. So that's my view of the terrain. That may change in the years to come, but I think it's going to be definitely a part of any new concept we come up with. So looking at the neurodegenerative disorders first, I guess, Ken. So the most common one in the world is Alzheimer's, followed by Parkinson's. Alzheimer's is huge, and Parkinson's is a distant second, but still the most common number 2 by far. They're both doubling every 20 years or something. So they're actually, this is faster than population growth, and they're becoming more common, unfortunately. Number 3 is probably motor neuron disease in terms of how often it appears. So incidence, unfortunately, people with motor neuron don't live very long. So in terms of prevalence, it's a little lower. In terms of how many people actually have it right now, it's lower. And then there's things like Huntington's disease. There are other rarer ones. So things like multiple systems atrophy and spinocerebellar ataxias. And, there's quite a few other lesser well-known neurodegenerative disorders, which in theory this stuff should work for as well, but I haven't got people with all those lesser known ones on these strategies. Now, people with Alzheimer's and Parkinson's, Alzheimer's doesn't have a good germ theory treatment at all. We try a few medications that can bump up in some people cognition by a little bit for a few months. The average is 6 months, and the common saying is after 6 months you're back to where you started. And often there are side effects, so it's very unsatisfying for Alzheimer's. Parkinson's does have a good medication called levodopa, which is Cinemet or Matapar in New Zealand. And actually, you can work that medication, time it properly, and use different formulations very well for 5 to 10 years and help people with quality of life. So that's an example where germ theory can work pretty well in Parkinson's before time. The Parkinson's relentlessly progresses. And what I always try to do with patients, I see a lot of Parkinson's. I see probably most of the Parkinson's in my region of the country. And as I try to work medications as much as I can to get the best effect and, help people understand their condition. That's really crucial. Understanding what it is that ails them is so important. I also try a multifaceted approach. So I will speak about dietary stuff a bit. In the first consult, I'll just mention to people that, it's probably good to get off processed carbohydrates, maybe implement a little bit of fasting, sort of a 2 meal a day strategy, or 16 and 8. Think about it, but I don't push it. And if someone's sort of resisting, then I definitely don't push it. And I don't mention keto diets unless someone's interested or in further consults down the road, because, for various reasons. And exercise is important. You got to emphasize other aspects of lifestyle beyond the dietary. So, there's certain exercises that are good in Parkinson's and Alzheimer's and so on. So really, it's about a multifaceted approach with respect to this improving mitochondrial health that's important. Now, in our studies, what we've shown is, as you said, Parkinson's, we did the world's first randomized controlled trial of a ketogenic diet in Parkinson's against a low-fat, high-carbohydrate diet. The low-fat, high-carbohydrate diet was full of fiber and fruits and vegetables and good things that someone would say that's good, but it was very low in fat. And the keto diet was obviously the opposite. It had green veg, but it had a lot more fat. And both groups improved by sort of 20% in their movements, and both improved in all these other aspects of Parkinson's disease, which we call the non-motor symptoms, which are actually more of the problem with people with Parkinson's. You get a lot of these non-motor things. So it's things like bladder problems, sweating problems, you get depression, anxiety problems, you get cognitive problems, you get swallowing problems, you get gut problems. There's just so many problems that they improved in both groups, 10% in the low-fat group and 40% in the keto group. So the big finding from that study was that the keto group, wow, they improved their non-motor symptoms tremendously by 40%. That's an absolute improvement. So 40% from the top, it's not a relative improvement. The relative improvement would have been like, 400% or something like that. So, it was a massive improvement in just 8 weeks. And that was exciting because the medication levodopa that I mentioned doesn't work so well for most of those non-motor symptoms. So that was an example where, we were using a germ and sort of, terrain or mitochondrial theory approach to help these people with Parkinson's. And it seemed to have a powerful effect. Alzheimer's, we did a trial in that too. And that was a randomized crossover trial. As you said, that's like the most powerful design you can get in terms of any kind of clinical trial, really. And that was people that we had them sort of 3 months, 12 weeks on a keto diet or 12 weeks on their usual diet with healthy, low-fat recommended guidelines and dietitian support at the start. And then, so we did that for 12 weeks, and then everyone had a washout for 10 weeks where they went up back to the usual diet everyone to try and wash out the good effects of or bad effects of either diet. And then everyone went on the opposite diet for another 12 weeks. That was very powerful design. And the Alzheimer's guys were looking at three things. So cognition, function throughout the day, and quality of life. Those are three main outcomes. And cognition improved in the keto group compared to the other group, but it wasn't statistically significant. So it almost got there, but not quite. And I think there were reasons for that. And it was during the COVID era. But their daily function improved significantly and in a clinically meaningful way, which matters more, in my opinion. So it's obvious to the patient and their family and to the doctors that the person has improved, and quality of life improved in a clinically meaningful way as well. So that was kind of exciting because Alzheimer's is a really tough one. Our medications for Alzheimer's don't work very well at all. So I got to emphasize these are preliminary studies, and they're powerful studies, but still on the small side. And we need to get more evidence before I can firmly say to people, oh, you should try a ketogenic diet or anything. And neither of them looked at fasting. So in future studies, I want to try and incorporate sort of keto diet plus fasting protocols in a combined manner and see if we can get even better benefit from that. But yeah, the studies have been very encouraging. But in my clinical work, I'm still saying, optimize your medications, whatever that may be, and then you can try this. I like to medically guide people through keto diets and fasting protocols because some people still get into trouble, as you know, if you don't watch certain things like water and salt intake, for example. It's encouraging, and I think what we really need to do is change the overall belief. Because many medical professionals, my colleagues, are steeped in germ theory and relying solely on that theory, that approach. And so this kind of approach, which is aimed at restoring mitochondrial biology in Alzheimer's and Parkinson's, it just seems weird and foreign. I don't detect antagonism so much as I detect just an inability to really understand why we're doing this. And a lot of people see that as a fad diet. They see fasting as a fad. Of course, these are evolutionarily ancient. We're supposed to be in ketosis most of the time. We're supposed to fast a lot of the time, and so on. So that's my approach with Alzheimer's and Parkinson's in a nutshell. I'm going to let you talk now because I've been speaking too much.
No, you're doing great. That's such excellent information. I want to ask you two questions. Both of the studies you did were using a ketogenic diet in at least one part of the intervention. Do you think that it's the production of ketones in the blood that's giving the therapeutic benefit, or do you think it's the removal of other things, excessive carbohydrates, possibly inflammatory things, or do you think it's a third thing, or is it some combination of all those things? What, in your personal opinion, based on your years of reading the literature and watching patients, what do you think's going on there?
Yeah, I think it's definitely a combination. I think it's a combination. So, like the Parkinson study is a great example. So that one group, everyone went off their ice cream and their beers and stuff in both groups, right? So the low-fat, high-carb group adopted a healthier diet in terms of getting rid of processed carbs than their previous diet, and the keto group, of course, did as well. There were almost no carbs in that diet at all, but definitely no processed ones. So both of them improved that aspect of it. And both groups improved in their motor symptoms and both improved in their non-motor. It's just that keto improved more. Now that keto improved more, maybe the ketone extra benefits of the ketones, which are an energy molecule that the brain can use, the nervous system can use, and the muscles can use very well outside of glucose, in addition to glucose, providing those might have been given the keto group the extra boost in their non-motor symptoms. And then I like to think, although 8 weeks is not a very long time, it is enough to get some aspects of mitochondrial biology repaired to some extent. And so I wonder, and I did not measure. I measured ketones every day, but I did not measure mitochondrial health directly, which I didn't have available at the time, the options. I may have them in the future. So I wonder if the mitochondrial health of these people in both groups might have improved, but the keto group more. So, because basically the problem with the modern diet, it's not just the processed carbs, it's the processed carbs plus high fat. It's this metabolic overload on mitochondria. When you have high carbs plus high fat, that's the worst of all worlds, because now you're attacking the mitochondria from two metabolic angles. They're metabolized differently. And so, that's why low fat, high carb is better than the Western diet. I think low fat, high carb has a role. And if you're very active physically, high carb, low fat will actually might give you superior performance in some aspects of athletics and stuff, particularly in younger people. But if you were looking for longevity, if you're looking for health, if you're looking to remove disorders like Alzheimer's, improve Alzheimer's, cancer, which is what the kind of person you and I see can, then you want to go high fat, low carb. And so that's some more ambiguity that I just wanted to clarify. I'm not anti high carb, low fat if it's not processed carb. That has a role and that can be good.
Yep, gotcha. And then Roxanne, one of our coaches in our private community, this is my next question, Roxanne. So I'll let you ask it. And so therefore, what about exogenous ketones? I know there's been a little bit of research done using them. And so you don't think it's just the ketones? You think it's also the removal of the highly processed, high glycemic index, high glycemic load stuff, and then possibly some metabolic healing going on under the hood. So what about exogenous ketones? This is actually one of the few times if a person can't get their grandfather to eat a ketogenic diet, to do any intermittent fasting at all, then my next answer is, well, get them some good quality ketone esters and maybe that'll give them some benefit. What do you think about exogenous ketones?
I'm not against exogenous ketones. I'm neutral. I've done a lot of self-testing with exogenous ketones, esters and MCT, and other things, coconut oil and stuff on myself. I've taken everything to the limits with myself in terms of side effects and tolerance, and I'm always doing something. I've got a continuous blood glucose monitor on right now, checking things out. So look, the reason I don't use those in my patients in my trials is, first of all, I like the idea of creating ketones intrinsically, because to me it's more about the ketones are like one instrument in the orchestra. They're an important instrument, but they're orchestra, which you can think of as really all the instruments in an orchestra contributing to mitochondrial health. The ketones are just one aspect of that, and I want to get at mitochondrial health. So I want the person to really get into the fasting and ketogenic diet protocols. Oh, hi, Kristen. So that's my take. Now, if someone is struggling to ketosis, I will help them focus on their fasting and low carb keto diet approach more. I don't mind. I don't have any patients. We're doing the current trial we're doing is glioblastoma. I don't have anyone who uses exogenous ketones in any of our trials. Actually, I do have patients who try them once in a while, and I'm like, that's fine, go for it. I don't think I think the ketones have benefits, but it's not the lion's share of the benefit. The lion's share is aiming to improve mitochondrial health. We measure ketones because they're a good marker of how well you're doing the whole process, how well the whole orchestra is churning. They're a great marker of that, but they're not the ends in themselves. So my take is neutral. I'm not against them. I don't see any downsides unless you take them too high. I have seen people get a little bit of diarrhea and gut pain from them, but they can ease back on them if that happens.
And I think actually that's a knee-jerk response back to the germ theory model, isn't it? It's like, oh, okay, so if you eat a ketogenic diet, then you produce these endogenous ketones. Let's just come up with an exogenous ketone and throw that at the problem. That literally is the blueprint of the germ theory model of disease. And so I think what Dr. Phillips is saying, and what I 100% agree in, is that this body of ours, and I also want to get your opinion on this. This body is so complex, so complicated, so ancient. To think that you're just going to come up with a molecule in the lab and throw that at the problem, and that's just going to fix the entire metabolic pathway. It's kind of sophomoric. It's juvenile to even think that way, but that's how billions are made, and so people think that way. I think that human metabolism, especially when you get down to the mitochondrial level, and what you said earlier, I love it that you know that, because so many doctors have no idea. They think that the mitochondria are just little bean-shaped things that sit in the cell and pump out ATP, and that's it. But mitochondria have their own DNA. Mitochondria are most likely captured bacteria that we captured. I forget what the time, 400 million years ago, that was the creation of eukaryotic life, is when two cells were able to work together and then reproduce together. We wouldn't be here if it weren't for the mitochondria. Wherever they came from, we just wouldn't be here. And so I don't think humans will ever be able to fully comprehend all of the metabolic pathways and feedback loops and negative and positive feedback, because I think many of them are still yet to be discovered. I don't think we are anywhere close to discovering them all. And I think once they are all discovered, if we can just say that as a hypothetical, I think it'll take AI to ever be able to globally understand human metabolism. So that's why I just get so triggered when somebody's doctor says, look, we understand all about this. You just need to take this. That is so juvenile of an opinion to have, and so uneducated, anti-educated, actually. And it's disheartening, but at the same time, it gives people like you and I hope, because we know that there's lots of room to learn and grow.
I think it's that whole belief paradigm. If you're working within the framework of a germ theory approach, you're always going to be seeking targets. And if you're within that theory, which I was until I finished my training as a neurologist, before I left for that 3 years, I was within that theory too. And it makes sense that maybe we'll find a magic bullet against Alzheimer's or Parkinson's, but now I don't think that's possible at all. And I agree. From an outside of germ theory approach, it appears like a strange thing to do. But when you're within that paradigm, it makes total sense.
Oh, I totally agree. Now, I've thought of a way to ask you, because we're going to now talk about practical things that a person who's been diagnosed with early stage Alzheimer's or Parkinson's or Huntington's, or they have a relative or a loved one who has early, mid stage, maybe even late stage. I'm not sure about that. Let's pretend, Dr. Phillips, that you have a hypothetical uncle. And so the things that Dr. Phillips is about to say is not medical advice. They are not his professional opinion. He is a researcher and a doctor. He is not your doctor. Okay. So none of this is medical advice. This is Dr. Phillips' hypothetical uncle has just called him on the phone and said, Matthew, old boy, I've just been diagnosed with Alzheimer's dementia.
Sure.
And I know you study that. I need you to tell me, because this doctor said a bunch of blah, 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 blah. I don't know what the hell he said. It was some bunch of big words. I need you to tell me, Matthew boy, simple terms. Do this, do this, do this, and don't do this and this and this. Talk to your hypothetical uncle, not medical advice. This is a hypothetical. And what would you tell this uncle on the telephone? Okay, uncle, here's what I think you need to do.
The most important thing, I guess, you got to find a neurologist or some kind of medical guide who's on board. Now, it's really hard to find a neurologist who's on board. I mean, I get emails from people all around the world every day on this, saying, it's frustratingly difficult to find that person. They do exist. But you need someone who's not just okay with it, but who actually understands it to a bit. And I always like to think if someone really understands it, they actually practice it themselves. I mean, why wouldn't you do fasting keto diet protocols if it's for health? So, as people already know, I'm a strict 1 meal a day keto guy. I mean, I'm pretty devoted to it now, although I started it for experimental reasons. I see it as a superior way to live. So you need to find someone. If you can't find a neurologist, then you find a GP or someone else who's got medical training, who understands the conditions a little bit, to help guide you. So there are a few online clinics out there that I often refer people to. There's in New Zealand, Australia, and the US. Now, that's the first thing. Once you have that person, that's so important. You need someone to watch you because, things can be done incorrectly. You can take the fasts too far or do them incorrectly if you do them really long. You can mess up the keto diet if you don't do it right. There might be other medical problems that you can fix with medications that will help you get through the fast and keto diet, right? So you need someone with medical training who understands the metabolic stuff, and that's hard. I'm hoping one day, like in 50 years, we have physicians who understand the sort of mitochondrial terrain approach and germ theory medication approach both well, and they can do that. But right now we don't. So after that, if you find someone, you're off. If you don't find someone, which unfortunately is likely, although you can find someone in an online clinic, then I would just start easy. So go low carb first. And I think a really good site for that, Ken, is dietdoctor.com. They have a lot of great low carb recipes, and they have keto recipes. So you can try the occasional keto one if you want, but just go low carb for a while. And to me, the real power is the fasts. So I say just go to 2 meals a day and no snacks. You can time those meals anytime you want. You have an hour to eat each meal. You enjoy that meal, and don't restrict yourself. Just enjoy it. And if you can go low carb 2 meals a day, I can't see how that would hurt anyone. You're not going to run into any electrolyte or dehydration problems. I've never seen this happen in that kind of a regimen. And that's like the training wheels for proper, sort of metabolic program is just knocking them 3 meals a day down to 2 and no snacks and going low carb. If someone succeeds with that, then we progress. So you throw in the occasional 1 meal a day, the OMAD, and then maybe depending on the condition, maybe you go for a greater than 24-hour, like a multi-day fast. But I do not advise those unless I can medically guide the person myself, or they have a guide of some kind. So don't do a multi-day fast, guys, anything over 24 hours, unless you know exactly what you're doing or you have a guide, ideally for the first few. So, and in terms of the keto diet, yeah, I mean, if a person's ready, we can go keto, and that's pretty easy to do if you know what to do. So, all these things, the keto diet, fasting, there's this fear amongst many of my colleagues about keto diet being dangerous and fasting being unsafe. However, it's like anything. It's like the more you know about it, especially from a personal experience, if you do a bit yourself, man, you'll understand a lot more about it that way than you could ever read. And then you'll be able to help a person with Parkinson's or Alzheimer's do it. And actually, I find my patients are truly incredible. That once they know how to do something, they do it. Our current glioblastoma trial is an excellent example. Our longest patients out to 3 years, these people for almost a year of their first year, they do a 5-day fast every 4 weeks, and they do 1 or 2 meals a day keto diet in all the other days, and they're all still doing it. So longest is at 3 years. Shortest is currently at about, I don't know, 5-6 months. So this is long-term, safe, and very doable. They have a good quality of life. I can't comment on whether it's helping them survive longer, but things at this point in time look good. So, these things, it's all about knowledge, and having a guide is the key thing. And after that, you can start low carb, a little bit of fasting, and build it up as you are confident. If you ever run into a problem, something's going south on a keto diet or a fast, then something is being done incorrectly. Something is almost certainly being done incorrectly, and you need to stop it right away, and or see a doctor who understands it a bit and find out what the problem is. So that would be it.
Yep. So, okay. So, hypothetical Uncle Bartholomew, he's like, okay, so I'm going to start eating 2 meals a day, and I'm going to go low carb. And your definition of low carb is under 100 total grams a day or under 50. What's your definition of low carb?
Yeah, I go under 100. Keto, I say 50, although you could be more hardcore and say under 20. Realistically, in our plans, we use closer to 20. But I don't want to get too black and white about those things. And I tell people, look, if you just follow the doctor low carb recipes, that's good, because one of the most hardest things for people, especially an older person with a cognitive issue, to do is track carbohydrates. And it's not very fun to do that. So I'd rather just, like, we have a plan that I give all our research people and just say, eat from this plan, any recipe, any time, and you'll be fine, because they're all tested in myself. So I know they all work. and they work in other patients. So yeah, I try not to track the glucose, but in general, low carb is under 100 grams a day carb, and keto is under 50. But you can vary those a little bit.
Yeah, and I agree with you. I find that in neurological patients, starting to talk about macros and total carb,
Yeah.
that's just going to be too much. So Uncle Bartholomew wants to know, what should I just absolutely stop eating and stop drinking? What should I
Yeah.
absolutely avoid?
Fantastic question. So first of all, I say it's really just 3 or 4 things. So unfortunately, alcohol, get rid of the beers. I do allow up to half a glass of red wine once a day. That seems to be okay for ketones. It depends on the person, but that's okay. No white wine. So second thing, get rid of all the processed, the obvious sugars, right? So anything with a big label on it in the supermarkets, processed, try to avoid that stuff, especially if you know it's got sugar in it. So sodas and juices are the big culprits there. Next thing is the breads and grains. So get rid of the breads. Doesn't matter how high in fiber they are, just get rid of them. The pastas, the cupcakes, the pastries, and so on. And then the last thing is fruits. So you've got to not remove fruits entirely, but really get rid of the fleshy ones. Stick the berries. So strawberries, raspberries, blackberries, blueberries are the best, not excluding avocados and things, of course, which are great. So limited amounts of berries. And I always say to people how many berries you can have in a day, and none of the fleshy fruits. And I also explain to people that none of these things I just mentioned, none of these 4 things existed before agriculture in any great degree in our diet. So alcohol did not, was not a hunter-gatherer thing. They did not, go out and drink beer and wine. The processed sugar was not a huge component of any hunter-gatherer society. There's some in Africa and so on, the Hansa, used more honey and things like that. But this was not like a huge proportion, the majority of their caloric intake or anything like that. So it's evolutionarily abnormal to rely on lots of sugar throughout the day. The grains is an agricultural thing, so all the barley and the rice, all these crop-based things. That's an agricultural thing in the last 10,000 years, and before that, we didn't subsist on that in large degrees. And of course, fruits have changed drastically. Farming has changed fruits drastically. Like watermelons, originally were much smaller. Peaches much smaller. They have more fiber. They've been selected to be more tasty and full of sugar. So that's why the fruits are not actually normal anymore either. Berries are sort of are okay because they've wild berries have sort of escaped a lot of that selective pressure by farmers. So when you explain it in evolutionary terms, and then you explain in mechanistic terms how to do it, then people, their eyes light up and they understand what to do. And I find, once they understand, the understanding is key. If you can relay the understanding to someone, see this is why, then they can do it.
So find a healthcare provider who understands keto and intermittent fasting. Cut the alcohol down to no more than a half glass of dry red wine a day. Don't eat any fleshy fruits that are been bred to be basically giant sacks of sugar. Eliminate all the grains. Grains are not an ancestral food. They've only been around in any percentage of our diet for the last 8 to 12,000 years, depending on where your people are from. Get rid of all the added sugar, definitely, but most of the naturally occurring sugar as well. Now, this brings up a good question that you may or may not be prepared to speak on. In the keto community, there are some huge proponents of avoiding all vegetable seed oils. And there are other people who say, the research is kind of lacking. What have you found in your clinical experience, but also reading the studies? What do you think about canola oil, soybean, peanut, sunflower, safflower?
Okay, I'll say 2 things. So I'll address the seed oil thing, and then I'll address the carbohydrate thing again a little bit. The seed oils, look, I don't know is the answer with the seed oils. I've been aware of the potential problems with seed oils for a long time. It makes evolutionary sense to me. So I do not use any of the seed oils in our plans, the canola, the rapeseed, or NSF. I emphasize olive oil, coconut oil, macadamia oil, avocado oil, and of course tallow and animal fats. So that's it. So every single recipe in our plan is that. I try to, and I tell people when they go to a restaurant, if they don't know If it says olive oil, make sure you check the bottle and see how much of that is true olive oil, because it's often
Mhm.
not, as you know, Ken. And I even say just bring your own little bottle of olive oil to be safe. And that's what I do. So just to be safe, I've avoided it. To me, I'm not sure the evidence is quite strong enough to really demonize seed oils, but they don't make evolutionary sense. So I'm against
Agreed.
it. I should say evidence comes in layers. Now, there's only two forms of evidence that I really trust the most, and I'm a hardcore on this. One, it has to make evolutionary sense. Whatever you're trying on a person to help them has to make evolutionary sense. And of course, we've talked about fasting, keto as evolutionarily ancient things here. The other thing is human interventional trials. You need trials that are on humans, not mice or animals. Those are useful to a limited degree, and you need interventional trials. That means someone did something in a randomized trial or a clinical trial, and then you follow those people up and see what happened. It's not an observational trials where you just correlate things are dangerous. And as I said, if you have a belief, you're going to read into an observational trial based on your belief. And as David Hume said, it should be the other way around. You
Yes.
should proportion your beliefs to the evidence, but people proportion their evidence to their beliefs, unfortunately. So human interventional trials, and that's why I've focused on, randomized control designs and even case studies where you do a properly done case study can be useful. And so evolutionarily, it has to make sense as well.
Absolutely. And then you were going to address the carbohydrate question again.
Just quickly, yeah. So look, I'm experimenting. One of the reasons I have the glucose monitor on now is for people with cancer. Like in our cancer study, I'm trying to get the carbs as low as possible and go hardcore metabolic fasting keto, because you have this cancer, which is, glioblastoma is terribly aggressive, and we're trying to control this thing and suppress it. But in neurodegenerative disorder like Alzheimer's, Parkinson's, Huntington's, although our trials have just used keto diets to improve them, and we have seen benefits in 8 to 12 weeks, I wonder in the longer term if cycling small amounts of carbs in periodically, so as you know, that's called a cycling ketogenic diet, might be beneficial for these people for many different reasons. So I'm actually experimenting now by cycling in small amounts of berries, only berries, and I know exactly how many carbs are coming into me, and not a lot, like a couple times a week, just to see maybe there's an advantage to sort of going out of ketosis or low ketosis very briefly. Because in these disorders, it's more about the neurons withering away and dying, and you're trying to rejuvenate them. Cancer, you're trying to chill out these abnormally growing cells. But in these disorders, the neurons, you want to rejuvenate them. Both disorders I see as caused by mitochondria problems ultimately, but sort of different ways in which they manifest. So I should say I am experimenting with cycling ketogenic diets at the moment, and I wonder in the future if that might be even better than going straight keto, because our ancestors would have been ketosis most of the time as hunter-gatherers, but not necessarily all the time.
So we've got hypothetical Uncle Bartholomew. He's on a ketogenic diet. He's eating 2 meals a day. Therefore, he's got a limited time restricted feeding window. He's got a longer fasting window each day. So he's in the fasted condition for more total hours a day. I would also guess that you're probably telling him not to snack in between those 2 meals, have 2 discrete meals with no snacking. He's going to cut down, get rid of the beer, drink a little bit of red wine every now and then. Now, what would you recommend, if anything, sleep and movement, exercise? What would you recommend?
Okay. So first of all, during the fast, I'll tell Uncle Bartholomew, you got to drink water, okay? And you can have tea and coffee, no sugar, a little bit of cream maybe, or coconut oil or butter in the coffee. Why? So based on observational studies only, people who drink more coffee get less Parkinson's and less Alzheimer's. And it's quite a strong effect. It's a very consistent effect. This does not mean that having less coffee or having more coffee and having more tea protects you against them, but it is an association. At least it does not seem to be harmful in any way. So I say, as a nice hunger suppressant, if you like coffee or tea, have some black coffee, have some tea. That's fine. I usually limit it at sort of 3 cups a day, because coffee can screw up your blood glucose a little bit if you take too much. Now, in terms of the other things, so great question, Ken. We're only talking about dietary stuff here. Let's expand that. So, other problems with these neurodegenerative disorders, we know that toxin exposure is a big thing. Like, for example, people with Parkinson's, the number one environmental risk factor is occupational exposure to pesticides and herbicides. people with ALS, for some reason, people who work in electrical occupations are really susceptible to ALS, whether it's the electromagnetic field exposure or repeated shocks or whatnot. Alzheimer's, air pollution is a big one there, right? So you want to clean up your environment in terms of either removing yourself from a bad one, too much air pollution, or maybe you're a farmer and you work with pesticides all the time. You want to remove those things. When by the time you get the disorder, obviously it's almost too late. But if you have a family history of this, or even Uncle Bartholomew, I can't see how having toxin exposure would be a good thing. That's number one.
Right.
Number two, in terms of the evidence, and this is all evidence based now. So cognitive stimulation is really good in Alzheimer's, and Parkinson's, the other disorders to a degree. So anything that requires a bit of tension and focusing of your cognitive activities, a lot of studies are done with board games like chess and Go and things like that. So that appears to have clinical benefits in these disorders. So do more of that. Less TV watching, less passive stuff. Use your brain. Exercise is good. Now, the exercise protocols, got to be careful. In ALS, motor neuron disease, too much exercise is a strong risk factor. So I think, but not enough exercise is a problem too. So you want to have some kind of exercise protocol. And I would argue that the evidence slightly favors strength-based protocols over cardiovascular endurance stuff. Okay, so get some kind of strength resistance training in there. If you can, sprints are awesome. If you can't do that, just use some kind of, obviously a lot of these people are older. So, well, you can still sprint up to a high age, I'd say, but do some kind of strength-based regimen. It doesn't mean you can't do some kind of endurance exercise, but get something strength related in there. And socially, people who are chronically socially isolated are at risk of Alzheimer's, Parkinson's, so on. This social isolation is not good. Our brain needs to connect with people like you and I are doing now, and just discuss things and just share ideas. So join groups. Don't be sitting around home all day on your own, especially if you're unmarried. Not having a wife or husband is not a good thing for these things. And so that's important. And now that's all so I divide these things into the active and the passive. That's all the active. Your diet, your cognitive stimulation, your physical stimulation, exercise, and your social stimulation. Now the passive. So yang and yin. The passive is just as important. Now, you can have a great diet, but you need to have those fasts. Okay, that's the passive. That's where you're just doing very little and letting your body recover. The equivalent of fasting for cognitive and exercise and social stuff is sleep and proper therapeutic resting protocols that alleviate stress levels on a metabolic and hormonal level and get your body into the state where it can recharge between episodes of cognitive stimulation, between the exercise sessions, and between any intensive social stimulations, social engagements, and so on. So if you do these things properly, it's tiring. So example, I ride a motorbike. I just love riding, and after a few hours of riding, because I've been paying so much attention, I am exhausted. My brain's tired. I need a proper rest period. So your sleep is a huge part of that. Uncle Bartholomew, you need to give yourself absolute sleep opportunity every night in a quiet room with no screens in that room, nice and dark. Try and have some ambient noise to get rid of random noises like dogs barking and things like that. And in terms of resting protocols, there's so many things that one can try. So you could try meditation, you could try mindfulness, you could try breath work, you could try non-sleep deep rest protocols throughout the day. That's my personal favorite. You can try forest bathing, so just immersing yourself in the forest. All these things are wonderful for your brain, allow your stress to go down, and allow you to properly recover between the exercise sessions, the cognitive sessions, and socially stimulating experiences. And of course, along the social lines, I also say to people, this is my theory because the evidence is weak, but I do not think a lot of aspects of digital media are healthy for the brain. It's kind of artificial to engage with people too much over screens, Instagram, TikTok, and all these other things that I don't fully understand. But it's the brain evolved to deal with people in a realistic scenario. You and I are having this conversation on a screen because we have to. We're halfway across the world from each other. But ideally, you want to engage with people in a real way and have the occasional digital media fasts. So you take just like you fast from meals, you want to fast from digital media. So you say, I'm only going to check my email once or twice a day at this time. I'm only going to check Facebook once a day at this time. That's actually important. I think the brain, this is not a good thing, and it may impact in mitochondrial biology at a level too. Not giving yourself that sufficient time from digital media. So that's the big picture of what I'd say to Uncle Bartholomew. And of course, what we're talking about is how to make your life as a whole better, not just your dietary lifestyle, but the whole darn thing.
Yes. Now, that's such great advice. And I think it's so easily applicable to anybody who's listening to this. If they've got an uncle or a grandfather or a grandmother, they can start to implement these things immediately by either making them keto friendly meals and taking to them. By if they're doing the grocery shopping, oh my God, I forgot the Honey Nut Cheerios, but I did get you some bacon and eggs, right? And just with slowly, gently replacing the high carb inflammatory crap with real actual human food that's high in healthy animal fat and healthy animal protein. Now it's been a week and Uncle Bartholomew's called back and he's heard about the carnivore diet. And he's really excited about that because he loves ribeye. And he says, can I do carnivore? Is that keto enough? What would you say to Uncle Bartholomew?
Okay. So the last thing I would say, I will address that, Ken, but briefly,
Okay.
I tell my patients, watch out for negative stigma and perceptions against this approach, the keto fasting, because the rule in society is that most people don't understand these things. They think they're bad. What people don't understand, they tend to think, they tend to be very skeptical of and cautious against them. I said, just expect that. This is the hardest thing of following these things for people is not the fast or the keto diet. It's the negative perceptions for so many people, family members, friends, health professionals included. So that's what that scares me the most when if someone's going to get derailed, it's because of lack of support from everyone around them. We're very social creatures. It takes a very rare person to be obstinate enough to keep doing something when everyone says it's wrong. Now, if the person comes back and wants to go carnivore, I'd say, okay, why? Is what we're doing not working? So maybe it is, and they want to go better. So then I say, okay, look, I focus on ketosis as the method. I like fasting and keto diet because they get you into ketosis, which is our evolutionarily normal state most of the time. We want to be using ketones and glucose both in ketosis, physiological ketosis. So as long as you're doing that, it doesn't matter to me too much whether it's carnivore, omnivore, vegetarian even. I do have people on vegetarian diets that do well if they're in ketosis. Now, I do watch them more carefully because, as you know, Ken, vegetarian diets, there is a risk of deficiencies, particularly B12. You've got to be very careful with that. So I watch them a little more carefully and make sure they're getting some kind of B12, but it's doable. Omnivore is great. Now, if they want to go carnivore, I'm all for that. What I say to people is, to me, carnivore is a great method for getting in keto. The advantages of carnivore, and I've got a couple people in the glioblastoma study doing carnivore. It's easy. It's easy. You just get your meat, you cook it in a bit of fat, so steak and butter or whatever. You're going to get all your vitamins and minerals. It's not, you don't have to even think about it. If you've got some good quality meat, you're going to get that stuff. You can virtually ensure there's no carbs coming in. So you are going to be on a strongly ketogenic diet. It's going to be higher in protein. But guess what? If you have a higher muscle mass, you're a bit more active. That's a good thing. And indeed, it tends to be the younger men, relatively younger men in my studies who want to be interested in carnivore. And so that's fine. And that third thing I say, look, especially if you're, Northern European or Northern Asian background, or Inuit. I don't have any Inuit from Northern Canada here, but this is actually probably your traditional diet for where your ancestors evolved, anyways. So you go for it. And that's why I find the people that are interested in the carnivore tend to be European background, Northern European background, and people of more Southern European, Asian, Indian background. They're more interested in getting the vegetables in. That's fine. So I can work with all of that, and as long as they're in ketosis, and which to me is that state where you're providing benefits for your mitochondria, I'm good with that.
Man, this has been priceless. I appreciate you taking the time today, Dr. Phillips. Now, everybody watching, thanks for hitting the thumbs up button. Thanks for sharing this. Down in the show notes, you will find links to Dr. Phillips' website and also to relevant research articles that he has published using a ketogenic diet in the treatment of Alzheimer's and of Parkinson's. He's working on a study right now for glioblastoma, which I predict is going to be that's going to change a lot of stuff. Could be wrong. We'll see what the actual evidence says. Yeah. Also, Huntington's. I think you have a study going on for Huntington's as well.
It's in the conceptualization stages. Good, so good. Watch this space. Yeah.
Good, because I think you're going to see beautiful benefits there as well. Thank you so much for doing this, doctor. Any final thoughts for somebody who is worried about a diagnosis of a neurological condition or taking care of a loved one with such a diagnosis?
Look, these are these are the worst of the worst disorders in medicine in many ways, because they impact families, like cancer, Alzheimer's, when your personality is being changed and so on. It's very difficult. So look, I just say to people, first of all, hang in there, understand that every day is going to be tough, and some days will be easier, and you don't have to be perfect, and just try to work with the whole process. Keep looking for things that make that person better, no matter what they are. If you get benefits outside of any of the things we've discussed here today, go for it. And yeah, just I think my take is that we can do a lot more good for these disorders than we are currently doing with our germ theory oriented approach. And if we can just alter our beliefs and expand them to include other beliefs, maybe we can get a lot more benefit for people with these disorders. And yeah, I would say people should just remember, whenever you see arguments on mainstream or social media or something, and everything seems confusing, it's probably a clash of beliefs more than an actual clash of facts or science. And you just got to figure out, like, where's this person, what's their belief, and what's this other person's belief. And if you can understand that, you can sort of see why they have such a strong opinion and maybe saying things in not a very nice way. And then you understand that it's like, okay, that's okay. They're just they have this belief, and maybe they're not there yet with a more expanded approach, or maybe I'm wrong. And always remember that one could be wrong as well. But yeah, it's all about beliefs, and that's how our brain works. It's a strength and a weakness. That's it.
Beautiful, beautiful. Thank you so much for spending the time with us today, Dr. Phillips. I cannot wait to see how the glioblastoma study comes out. I'm sure you'll publish that either way. And just thank you for constantly thinking about not only the germ theory, but also the terrain theory, and how you can put those together to help the patients who depend on you as a neurologist. Thank you so much for doing this. I'd love to have you back on in the future when you have more research published.
Thanks, Ken. Yep, that middle road approach is the way to go, I think.